Welcome, everyone. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. And I'm excited to welcome you to today's webinar, COVID Vaccine for the 2024-2025 season, featuring Dr. Suzanne Judd, Director of the Lister Hill Center for Health Policy and Professor and Interim Chair in the Department of Health Behavior at the University of Alabama at Birmingham School of Public Health. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email us, arcipc@uab.edu, with any questions, and stay up to date about future trainings by signing up for our newsletter on the homepage of our website. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety, and the Alabama Public Health Training Network at the Alabama Department of Public Health, part of the Region 4 Public Health Training Center. You can learn more about their programs and the centers as a whole at the websites listed on this screen. We'd also like to let you know about our next upcoming webinar with Dr. Louise Chavez from the Indiana University School of Public Health, entitled Climate Change Impacts on Vector-Borne Diseases. Dr. Chavez will present results from his research on malaria and other vector-borne diseases that have illustrated the importance of climate change to understand emerging ecological and epidemiological patterns on the transmission of vector-borne diseases. This webinar is presented by the Alabama Regional Center for Infection Prevention and Control and is co-sponsored by the Deep South Center for Occupational Health and Safety, the Alabama Statewide Area Health Education Centers, and the Region 4 Public Health Training Center. And it will be held on October 23rd at 11 a.m. Central Standard Time. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must, 1, register for the training, 2, watch the entire program, and 3, complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CE units for this program will expire on October 1st, 2025. If you experience any issues, please email arcipc@uab.edu. And finally, it's my pleasure to introduce our speaker. Dr. Suzanne Judd is an investigator with the ARC-IPC, and she is also the director of the Lister Hill Center for Health Policy and a professor and interim chair in the Department of Health Behavior at the University of Alabama at Birmingham School of Public Health. She received her PhD in nutrition sciences from Emory University, where she led 2 vitamin D clinical trials. Dr. Judd is multiple principal investigator on both the REGARDS and rural cohort studies, which are large NIH-funded epidemiological cohort studies seeking to understand disparities in chronic diseases in the United States. Her experience in the U.S. provided a platform to collaborate with European cohort studies in France through the Fulbright Scholar Program. Her unique combination of training in engineering, epidemiology, and nutrition, as well as industrial experience, have provided a solid foundation to guide her research, mentorship, collaboration, and public health communication. So without further ado, I want to hand things over to Dr. Judd. Thank you for being here, Dr. Judd.
Oh, thank you, Mina. It's always great to be here and get the chance to talk to folks. So without further ado, we'll get going. Today, we're going to focus on COVID vaccines for the 2024-2025 season. And we really can't start talking about vaccines until we think about what's the overall goal? What's the purpose of our vaccine programs? And when we think about it, it really comes to us with the field of epidemiology, where we're studying what types of conditions happen to people. Epi means upon and demos means people. We know that infectious diseases have been around for millennia. They're in literature, they're in history. There have been numerous times throughout history where there were infectious disease outbreaks. Interestingly, cities were always considered one of the places that were more at risk for infection, particularly up through the early part of the 20th century, when we started to have changes in the way that sanitation and public health administer their programs to make cities a little bit safer than what they were before the early part of the 1900s. We have some very famous historic outbreaks that people, even today after COVID, everybody knows that the famous historic outbreaks, but the influenza, pandemic influenza that occurred right at the end of World War I between 1917 and 1918 and really wiped out a large portion of the young population worldwide. One that people don't always think about as much, but it's the one that got me interested in epidemiology was HIV. And HIV spread throughout the 80s and 90s, the latter part of the 20th century. Historically, you'll also see a lot written about the plague in Europe because it was very socially, it had many social consequences. And then, of course, we all have lived through COVID-19 that was only just a few years ago. If we look at infectious diseases in the 20th century, which is really where we started having changes to public health infrastructure, we noticed this trend where infectious diseases really plummeted, both in terms of age-specific mortality rates and how many of the total deaths in the United States were attributable to infectious diseases. Both of these lines go down very rapidly, beginning right around 1920, with that one peak in there for the pandemic flu in 1917 to 1918. So we see a lot of changes in terms of infectious diseases in the United States. A lot of this is due to our classic epidemic management strategies. We can suppress an infection when we start to see that it is starting to balloon in the population. We can try to eliminate human-to-human transmission, reduce the amount of time people spend together, or we can try to mitigate consequences, which is the primary strategy we use for most infectious diseases in public health. We're not trying to eradicate the virus. I mean, of course, we would love to, but the reality is it's very complicated to do. We're trying to minimize what's the impact of this virus, this bacteria, or other pathogen to human health, which is, in other words, we're trying to figure out how to live with it. Vaccination is one strategy that we use to help us live with various infectious diseases. It's made it into popular culture in many forms. For those of you that have children or you yourself enjoy gaming, there's a game called Pandemic. And one of the most effective strategies in this particular board game, there's also an app that goes with it, is rolling out an effective vaccination campaign. So even the makers of games realize how important these vaccination campaigns are. One of the challenges we have with vaccines is misinformation. And I think it's important that we don't ignore the fact that there is information out there that people get, and they start to think that all information is bad because there are certain pieces they get. These are some historical ads. Some of them are for mitigating the flu back at the turn of the century, bromoquinine tablets that were marketed to reduce the complications from colds and influenza. The most classic one I like to show is the snake oil, because this is something that came about in the United States because there was one particular person that was selling snake oil. He had worked with some of the Chinese laborers who were using something like a snake oil. He actually did something very different with it. The one that the Chinese immigrants were using had very high concentration of omega-3 fatty acids, which we all know is very good for human health. He was using a very different oil and marketing it, and of course, it wasn't providing any benefit. But this is where we get that term snake oil salesman. from these historical um, advertising that happened. I also put some modern advertisements on here because you can see we still get marketed on a regular basis, whether it's Dayquil to help reduce the cold and flu symptoms, or as we all saw, ivermectin during the pandemic, and then IV therapy. You can see these IV therapy places all over Birmingham that pop up for people to get, restore their vitamin levels and ward off disease. So people are inundated with lots and lots of information. How do we help to give them good information? Well, in 1902, the Congress passed a law that became the basis of what the Food and Drug Administration is today, the Biologics Control Act. This was really designed because there was no control whatsoever. It was fully unregulated. People could claim vaccine that they were creating a vaccine and giving it to people and that it would work, but there was no requirement on how much antitoxin would be in it, what the licensure was, and how the plants that were manufacturing it or the facilities that were manufacturing it, how they'd be inspected. When this law came about in 1902, roughly 1/3 of the companies that were manufacturing antitoxins and vaccines, they had to file bankruptcy because they couldn't comply with the new legislation. That just shows you that the market was fairly unregulated, leading to some maybe unsafe practices in the terms of vaccine distribution. Today, we're in a very good spot because we've had the FDA around now for over 120 years, monitoring the life cycle of vaccines to keep us safe. This is the way vaccines are developed. It's the life cycle of a vaccine. You get very basic research early on. These might be tested in labs. They might be tested in cells, just in culture, not even in an animal whatsoever, to look to see if various compounds will either stop a virus from replicating, make the environment hostile so the virus is unable to replicate, or actually destroy various bacteria and viruses. You can see that first in the lab on the bench, and then move into some of the preclinical studies where we start to test it in humans. The clinical studies trials in the green are the area where we start testing in humans. We first look at safety in a very small group of people to make sure that there's no allergic reaction, it doesn't cause any adverse events. After phase 1 makes it through safety, then it moves into phase 2, which is looking at effectiveness. Does the vaccine do what it's supposed to do? Does it actually either prevent infection or reduce side effects, keep people out of the hospital, whatever the goals of that particular vaccine is? After that's done, which is in more like the hundreds of people, then we move into phase 3 trials, which are the big, broad trials to put it in thousands of people before it's rolled out to the market. After the phase 3 trials, it again goes to the FDA so that the FDA can review the safety and efficacy data to verify that what's being tested actually works. The FDA will approve a vaccine and give it either conditional approval or full approval, depending on how long it's been in the market. And then it goes into phase 4, which is unregulated. Anyone can use the product either with doctor's prescription or going to a pharmacy, however that particular vaccine is administered. But even in phase 4, we continue to monitor various vaccines for side effects because there can be issues. Any drug, whether it's the vaccine or a manufactured drug, the FDA is always watching to make sure that there are not manufacturing errors or some type of a batch error to better understand that a vaccine's working. And I can give you an example of this for myself. In phase 4 monitoring, I was getting ready to go to Europe for the research that Mina mentioned, and my doctor took a look at my history of immunization, and she said, "Oh, we see that you had an MMR vaccine in Michigan when you were about 15. During that time, it's pretty well known that there were a couple of batches that were not as effective of MMR, so we're going to test your antibodies to see if you actually have antibodies." Turned out I didn't have enough, and I had to get an MMR booster. But they could tell that based on this phase 4 monitoring that in this area there were people that were not having as robust of a response to the MMR, and so I wound up with an MMR booster. All that comes out of phase 4 monitoring. So one thing that is absolutely clear is that vaccines do decrease infectious disease, the way they spread, the dangers of infectious disease. And we've been using some form of vaccine for way longer than people realize. People think that vaccines are a newer form of infectious disease management, but actually they go way back to the even the Middle Ages, where they would use, basically from a smallpox lesion, they could take the pus from a smallpox lesion, inject it just under the skin of a person that was healthy. The body would mount an immune response, but not necessarily get smallpox, although it did result in smallpox transmission sometimes as well. But still, it was better than if someone contracted smallpox and then wound up with a full infection. Um, Even in the early part of the 1800s, there were some cholera and typhoid vaccines that were circulating as well. I mentioned the 1902 that helped to get the FDA started and keep the vaccines a little bit safer, but also something that people don't think about, but in public health matters to us very much, is that in 1905, the Supreme Court ruled that vaccine mandates are constitutional. In societies where we're trying to keep people safe, we can have required vaccination policies for people to participate in that society. After that, we had the flu vaccines that became licensed in the 1940s, which is when we start to see a real decline in the mortality due to infectious influenza. And at this point in 2020, I should have updated it for 2024 to see if anything's changed, but it's the recommended vaccines for most people here in the US are diphtheria, tetanus, pertussis, measles, mumps, rubella, polio, Haemophilus influenza, hepatitis, varicella, pneumococcal, and rotavirus. We also, of course, have COVID. We also, of course, have RSV. So lots of different things. You've noticed how much it's changed over the years. We talked a little bit about what that FDA development cycle is to keep the vaccine safe, but also another historical perspective. George Washington actually mandated inoculation for the Continental Army, where they'd take the pus from an infected individual and insert that pus under the skin of non-infected individuals. We've got the lab development now so that you don't have to rely on something like getting pus from an infected individual. And we talked about those phases of clinical trial management. The most important piece is that with clinical trials, we work really hard, although we don't always manage to get representation from a wide range of people, but the studies that are doing the clinical trials try hard to get different ages, different races, different sexes to make sure that the vaccine works broadly for all Americans. The question with any vaccine, and when I talk to people, because I do talk to a lot of people, some are like public health professionals, and obviously we're much more comfortable with vaccines, but also people in the community. One thing I like to talk to them about is you're going to get immunity from COVID one way or the other, or whatever the vaccine is that you're looking at. Today we're talking about COVID. How do you want to get your immunity? Do you want to get your immunity in a case where you're running with the virus, a totally unregulated immune response that might lead to hyperactivity of the immune system, autoimmunity following this disease, some risk of death during the pandemic and also hospitalization, or the consequences of the vaccine, which are, maybe 1 in a million do develop myocarditis, which typically resolves, might have a little pain in the injection site, and you might have some fever-like symptoms, maybe miss a day of work after the vaccine. It's much milder than what would happen with the actual infection. That said, though, I think it's really important that we take a minute to pause and think about people who are not getting vaccinated, so that we understand various perspectives and can work through some of those perspectives to help them to potentially consider getting vaccinated. Why do people get vaccinated? Some people get vaccinated because they're very afraid of whatever they're being vaccinated against, whether it's COVID or pertussis. They're afraid of the disease and they want as much immunity as possible. Generally, those folks are pretty easy to get to come in and get their vaccines. These people are also typically very compliant with other recommendations from the general medical community, so they probably have better access to care, more likely to be managed for other chronic conditions like hypertension and diabetes. Some people get vaccinated because it's required. So your child has to be vaccinated before they go to kindergarten, or you're a college student or a professor and you're interested in going somewhere internationally, and that country has vaccination requirements to get into their borders. Sometimes people simply get vaccinated because it's required to do the things they want to do socially. So on the other hand, why are people not getting vaccinated? Well, there is still a general fear of vaccines. There are a group of people that are very afraid of vaccines. Even with the process, we can talk about how it was developed and how safe they are once they make it to market. There's still a fear because a couple of reasons. One of those is that they're afraid of the needle itself. As much as it's hard to believe, there are truly people that are afraid of needles, and we have to be cognizant of that, to try to talk people through it, make the environment a little more friendly when they go to get their vaccine, to try to help alleviate their fear. They might not be afraid of the vaccine itself, but quite simply the needle. When I was a kid, it's not something my parents did, but I would hear people say things like, do this or I'm going to take you to the doctor to get a shot. This is a torture method that parents sometimes talk about with their children. So it's not surprising that some people have this fear of the needle. And so we have to try to help them overcome that fear. There are some people that generally just resist recommendations because they want to push back and have some autonomy over their own body. We want to use a different strategy when working with those folks to not come at them with the mandate. That's probably not going to work. Mandates, although if they need it for a job, it'll work. But societal mandates might not work as well as economic-based ones. But thinking about how we would differentially approach those people rather than you have to do this, trying to come at that from something else that internally motivates them to change their perspective on the vaccine. Some people don't get vaccinated because they have a perceived lack of time. Even though it only takes a few minutes, maybe you have to go online and make an appointment. Maybe you have to have paperwork put together to verify your last vaccination status, and they perceive they don't have enough time to get vaccinated. So wherever we can, we want to make the process as easy as possible to not have that be a reason why they're using. Some people might have a lack of resources, whether it's financial resources or a vehicle to get to where the vaccine is located. Again, we'll want to have different programs for those folks to make sure that we can get them vaccinated when they're ready to be vaccinated. And then lastly, we do have a group of folks that just generally don't trust the government. So we want to be very careful when we communicate with this group of people so that it doesn't appear like the vaccine is coming from the government, that it's coming from the best interest of neighbors and clergymen, whoever they trust for advice. So now let's talk about COVID. Let's talk very specifically about COVID. The COVID vaccine has been updated for 2023 and 2024, and it is providing effective protection against JN1 and other circulating variants. We have data from 2022 and 2024 that show, and this is again from CDC, I've got the links at the bottom. Mina's going to send you the PowerPoint so that you have these later on. But we know that people who received the updated COVID-19 vaccine last year for the 2023-2024 season, they were 54% less likely to get COVID-19. And we know that that particular vaccine had broad coverage, including XBB, which was most commonly circulating last year. And even when JN.1 became the variant, we saw some pretty good immunity. We also have this article from CDC that's listed down at the bottom as well, that the people that had a vaccine, the vaccination was 76% effective in keeping people off a ventilator. And that's really important when you're talking about quality of life and things that a lot of folks do want to avoid. Just to give you an idea, these are slides in general for those of you that are not in the vaccine world and don't think about how well we're doing at getting kids vaccinated, or not kids, you'll see we'll go through different ages. This is our most successful demographic. We are really, really good at getting kindergartners that are starting school vaccinated. We've got, data, we're usually for most vaccines, we're up in the 90 to 95% of kids that are entering kindergarten. And this is consistent. You see from 2008 to 2020, we're hitting that 90-95% every year for kids in this age group. Well, what about as we start moving into adolescence? Well, now as we move into adolescence, you'll see that we made some big gains from 2008. where we got people up above 80%. And now we generally hover for most of the vaccines out there, somewhere in that 80 to 90%, 85 to 90% range for adolescents. But again, often in adolescents, they still need an immunization card to continue through school. So it's a school-based process that we can use to make sure that people are getting vaccinated. Well, what about as we keep going up and become adults? These are lines for the Tdap vaccine or just the tetanus and diphtheria. There are a couple of different vaccines out there that when we ask people to self-report whether or not they've been vaccinated for these things, you'll see that back in 2018, when we started collecting the data on BRFSS, it was pretty low. We're looking at about 50% are maintaining their booster schedule in that 65-year-old age group. The younger folks were more likely to have been boosted on the right interval. But we also are making some gains here in 2020, but nowhere near the 80% that we saw of school-age children. Every adult group is below that 80%. What about influenza? This would be more of an elective vaccine that people have rather than one where Tdap is typically the doctor says it's been 10 years, we need to get your booster done. Influenza is more considered elective. How are we doing in that area? We're doing okay, and those over 65, you can see that's hovering in that 65 to ticking up toward 80 as we get into 2020. But when you look at the other age groups, when you look at the 18 to 49, they're very low. You're looking in the 30% range, and probably a lot of these have a job at a hospital or someplace where this influenza vaccine would be required. So you can see how much our vaccine coverage drops off with various age groups. Now let's look at COVID. These are the 2023 COVID vaccine stats. We're looking at extremely low numbers of folks who are getting vaccinated. We are seeing that they're getting vaccinated more toward the end of the year in this November, December timeframe. You can see how it's really ramping up toward the end of the year, but we're really only getting into that 25 to 40% range. Excuse me, that was for influenza. I was going to say that sounds higher than what I was thinking for COVID. But when you look at COVID, we're way under 25%. Even in the best, when we get toward the end of where people are more and more people are being vaccinated, we're way down in terms of COVID and people getting vaccinated. So they're more likely to get vaccinated for the flu than they are for COVID in the 2023 season. Well, what about 2024, 2025? What's new this year? So the new COVID vaccine is approved. The FDA gave it approval in August of 2024. We've got two different versions again, the mRNA version and the protein-based version. Novavax has the protein-based and Pfizer and Moderna have the mRNA. Everyone over 6 months old should get an updated dose of the COVID vaccine. That's CDC's recommendation currently. For the most part, as I mentioned before, the 2023 version had that XBB.1.5. Now the dominant version is JN.1, and that's what's in the 2024-2025. Both the Pfizer and Moderna mRNA vaccines also target the KP2 strain of this virus. What does that mean for you all? That they're doing a good job monitoring the various circulating forms of COVID, and they have developed a vaccine that is representing what's currently circulated. So it should leave us well protected for the 2024-2025 season. I put this slide in here just in case people wanted it. There was a lot of talk about this during the pandemic, but it is confusing. People hear mRNA, it sounds like DNA, and that sounds a little bit scary. Basically, what happens with an mRNA vaccine is the vaccine actually uses your body's own cellular mechanics to produce the protein that your immune system recognizes and says, okay, I need to build up antibodies so that these antibodies are hanging out in reserve if the real virus comes. It's not manufacturing virus, it's just manufacturing a protein that the immune system, that your own immune system will respond to. On the other hand, the protein-based vaccines, these actually inject the protein itself, that spike protein, into your body. Then your immune system reacts to it without using your own cellular mechanics. In fact, one of the reasons you get a little bit sore at the injection site with the mRNA is because it's the muscle cell that's helping to produce the protein. Here, this is just the protein itself that's injected. but it also has to be injected with the adjuvant. So a little bit different. The mRNA are a little easier in terms of manufacture. That's why they became so popular during COVID, but both are highly effective. And either the mRNA or the protein vaccines have been well studied and are effective. Who can get it? Everybody over 6 months. The mRNA versions are authorized for children, where the Novavax protein is only for those 12 and older. So if you're looking at whether you're vaccinating your child or yourself, there might be some slightly different recommendations. What if you just had COVID? That's a question people always have. Well, anyone who recently had COVID can wait a little while. CDC says up to 3 months you can wait after infection to maximize your immune response to that vaccination, because you do have a little bit of immunity after you have the COVID or have the COVID virus. So maybe you wait 3 months to give yourself a boost to your immune system with the vaccine. What if you've never been vaccinated for COVID? There are still folks who never have. So for the updated mRNA vaccine, CDC and FDA do recommend that you get a dose at least 12 months after the last dose. So you might be on a 2-dose regimen if you've never had a COVID vaccine before. Talk to your primary care doctor, talk to the vaccine clinic, make sure that you are getting the dose that you need if you've never been vaccinated for COVID before. Who's particularly vulnerable? What groups should really be thinking about vaccination? Anybody over the age of 65, or if you care for someone over the age of 65, spend a lot of time with someone over the age of 65. It's a good idea to you yourself be vaccinated so you can limit the way that you're potentially spreading the virus. Anybody with underlying medical conditions, including if you're immunocompromised, long-term care facilities where people are living in closer settings, that's a good idea to be vaccinated in those settings because you might be more likely to spread. And people who are pregnant, breastfeeding, or might become pregnant, there's great data on the clinical efficacy of the vaccination for both the mother who's pregnant and the unborn child once they're born. So the vaccine is beneficial to both. This is a great infographic, and I have the link so you can have it later on to everything I just said, but also includes the RSV, which people are starting to really lump together COVID, flu, and RSV as all of the upper respiratory infections that we typically get in a winter season. So this is a great infographic for who should get each of these various vaccines with current CDC recommendations. So COVID and flu, really everyone. We're recommending it to everyone who's 6 months and older. RSV is important for young babies and also older adults. So currently the recommendations are really for the youngest young and the oldest old for the RSV. Where can you get the vaccine? Lots of places. Your healthcare provider will probably offer the vaccine. You can check with them. You can also get it at pharmacies, CVS, Walgreens. You can register for an appointment, get both flu and COVID. The health departments, federally qualified health centers, rural health centers, really call around and find out, where you live, what's the best option for you to get that vaccine that also provides the most cost-effective way to get it. What if you need other vaccines? While you can get flu, COVID, and RSV at the exact same time, you can also spread them out. I know people that prefer to get their vaccines 1 to 2 weeks apart because they feel like their immune system can respond better. They don't feel as run down. I know other people who just want all 3 at the same time and not have to think about it again. This is really personal preference, but CDC says it's no problem. You can get all of them at the same time or split them up, and that you don't have to have any kind of waiting period if you do split them up. They also are starting to give some advice on pneumococcal, shingles, and whooping cough. Whooping cough being pertussis. There's evidence that pertussis is spreading again. So you might see some updated recommendations on pertussis boosters, but CDC is saying no problem, you can get that at the same time as well. And with that, Mina, I will turn it over for questions.
Thank you so much, Dr. Judd. This has been super helpful, and we've got lots of questions that have come in. I would encourage, we've got time, so if you do have questions, please drop them in the chat box and we'll answer as many as possible. 2 questions that are kind of related. Someone has asked about the benefits of the protein vaccine versus the mRNA, and does the mRNA vaccine maybe give a little more protection against current variants?
That's the thought. We don't have the data, but certainly from labs, or theoretical, we would think that the mRNA would provide a slightly better benefit to what's currently circulating, but both work highly effectively. Again, it does not have to have the very specific type that's circulating. What we found last year was that even when a different variant was in the vaccine, it still helped against future variants.
Perfect. Someone has asked a question, and I know earlier in the summer I heard some talk or saw some articles about a combination vaccine, flu and COVID. Someone just asked, is there continued research around that? Maybe even flu, COVID, and RSV? Any
Absolutely.
information?
There's definitely research. Um, this is one of those areas when you think about it from a practical standpoint, you understand better why we don't see more of it. Although all of us that are sitting in society think, "Wait, no, it's practical, just do it." But what happens is if a company decides they want to make a vaccine that's got flu, COVID, and RSV together, it has to go through that whole clinical trials process that I talked to you about. So they have to really start over from scratch, even though the three vaccines on their own might be completely safe and have already gone through all the safety and efficacy testing. To put them together in one vaccine requires the company to start back over from scratch. So there's not a ton of financial incentive for companies to do that. So we don't see it happen as often as we would like to see it happen. But certainly there are some companies that are looking into it. But as you saw this year, as much as they promised, it didn't happen.
Right. And I wonder if there's some concern too, to your point, of some people like to space out vaccinations, if people would be hesitant to get two or three in one shot at the same time. So that may be also playing a part into it.
Yep.
Is the COVID vaccine becoming more like the flu vaccine, where a new vaccine will be developed each year based on the variants that are seen circulating? And how often should we expect to see an updated COVID vaccine?
Yeah, that's exactly the plan, that there will be an annual update based on circulating variants, very similar to what has been happening with influenza for years. I think it'll stay on that annual cycle for now. One of the nice things about the mRNA version of the vaccine, it is able to pivot more rapidly. If for some reason COVID mutated in a way that was particularly scary or causing more hospitalizations, you might see a rapid update to the mRNA vaccine that would probably go off label and be under emergency use authorization. But for now, as long as we stay in steady state, I think you'll see an annual update.
Someone had a question, COVID recommendations if they are undergoing immunotherapy. Do you have any?
Definitely talk to your doctor.
Okay.
That's important. That's one of those conversations you want to have with your doctor to make sure that the vaccine is right for you with your current treatments.
Why do people get flu-like symptoms after receiving a flu or COVID vaccine? Does that mean that you have a strong or weak immune system?
You know, I like to tell myself it's that I have a really strong immune system. And I've talked to other infectious disease docs to ask them to study this question more because I'm somebody that has a terrible reaction to flu shots. I always have. I'm sick for 2 days afterwards. So what I like to tell myself is that it's because I got better immunity than my next door neighbor who got a flu shot, and it's like eating a candy bar. Nothing happened. But really, what it is your own immune system's ramping up. It's you're not being infected in any way, shape, or form. Your immune system's ramping up, and those same symptoms you would have if your immune system was fighting the virus, that's what's happening in response to the vaccine. Why some people have very robust responses and whether or not that translates into better immunity, those questions are not terribly clear, but I feel better every night telling myself that that's why I have to suffer for those 2 days.
Gotcha. Someone has said they have already vaccinated their residents. I'm guessing maybe they work in a long-term care facility for COVID, flu, and RSV over the past 2 weeks. Is there anything else that they need to offer or consider? Will there be a COVID booster in the next 4 to 6 months?
No, probably not. Not a booster. There could be recommendations to get a second shot, especially in long-term care facilities. Stay tuned to the CDC website to see what they say. It will be based on how the virus circulates and what's happening in specific populations. If they start to see outbreaks in long-term care facilities and they get some demonstrated benefit from a booster, you will see those recommendations to get a booster in those facilities. Currently, no, but stay tuned. That could change.
I want to switch gears a little bit. I know we've been focusing on the actual COVID vaccine, but to a couple of things that you talked about earlier. Someone early on said that they work with a population in Macon County that does not trust the government, secondary to the syphilis experiment. What is a good approach when communicating with them?
You know, I think it's important in that particular case to not ever come in as the government. If you can avoid it, if you can go in through trusted community health partners, whether that's community health workers, a health ministry at a local church or parish, um, any organization that does not come in specifically as this is the government, which includes, unfortunately, for a lot of us, public health. That's viewed as the government. So if you can work with some of those community partners, also holding listening sessions, as hard as it is to make time to meet with community members, it is so important to sit down, meet with the community members, especially the loudest voice. Whatever you can do to listen to the loudest voice about what their frustrations are and help address their specific questions. Sometimes that very community member who's been the loudest opponent to your plan can then be a partner. But it can be important not to show up as the government, because that often will backfire.
Related to that, and when you went over the reasons why some people don't get vaccinated, someone asked, are religious or political reasons? Can you touch on that a bit?
Absolutely, that's another great point. Some people do not get vaccinated specifically for religious reasons. It's important to talk to people about that. Oftentimes they will use religious reasons when their religion does not actually call for lack of vaccine. Some people do. There are legitimate religious concerns. Not legitimate. There are religious concerns that are founded in the religion. But then other people, they just kind of fall back on that and say, oh, it's because of my religion. So it's great to sit down with the person and talk to them and understand. Then again, reaching out to the parish leaders to find out if that is in fact the case, and what can be done to prevent disease spread in those particular situations.
We have someone who shared that they are expecting a baby during the winter cold flu months. Do you have any advice on talking with family who are vaccine adverse for unknown reasons about how important it is to help protect a newborn by being vaccinated?
Yeah, absolutely. There, CDC does have some great resources for that, so that you can start that conversation with them. Two pieces to this question. I'm not sure if you mean that you would like other family members to be vaccinated that will come in contact with the baby. That's a conversation where you can start to lean on some of the research that shows how well people that are vaccinated, it does help to keep them from spreading the virus to other people, to keep the baby safe. It's challenging. Those family dynamics are really challenging. If you're thinking more from in the vein of you're worried that a parent or a loved one is going to pressure you not to get the vaccine because they're worried that, if you're thinking about having a baby, they'll try to pressure you to not get the vaccine. That's another one. You can give them information to show it's very safe for pregnant women. It is also confers immunity to the fetus after the baby's born, and is actually a human. It's a great way to provide immunity and keep that child safe so that it doesn't get a severe respiratory infection, wind up in the hospital, which is every new parent's biggest nightmare.
Someone says their parents are worried about different health risks from these new vaccines because someone that they know had an adverse reaction to a vaccine. And I know you spoke on this a bit, but if you could just kind of reiterate, what are the potential risk and what is linked to anything linked to the COVID-19 vaccine?
Yeah, absolutely. There are certain risks. They're very low in the 1 in a million category, where myocarditis is the one that's been the most heavily studied. It's interesting to talk to people and ask them what their definition of risk is. I've had my own family members when I'm talking to them, and they'll say, you know, after I got the COVID vaccine, I never, I've had issues with uh, GI trouble ever since, or something like that, to talk to the person to figure out, well, what do you mean by an adverse event? An adverse event is myocarditis. That's serious. If you're talking about maybe some symptoms that popped up right at the same time, talk to them and listen to what they have to say. That's one strategy that I've found is very helpful. Sometimes people just want to talk about it and they want to hear you say, wow, that must have been really hard. Now you know, you're after you eat spicy food, whatever it is, you really, that sounds like that would be really awful. I can see where that would bother you. I wonder what would happen if you got another shot. You know, maybe that wouldn't happen next time. Just trying to have the conversation with them so that they feel empowered in that conversation. Again, first figuring out what they define as an adverse event or an extreme reaction, because people have, you'll find a variety of different interpretations of what a severe side effect from the vaccine is.
Someone says, I understand that there is less funding available for people who are uninsured or underinsured to get the COVID-19 vaccine. Is there a plan to provide greater access?
That is probably our biggest public health challenge with COVID in 2024. A lot of the programs that were in place that allowed for free and reduced vaccines are gone. Now there's still programs for children, but some of the programs for adults just don't exist. And currently, there is not anything that looks like it's coming forward nationally that will help address those gaps. There are private foundations working to address the gap. But it is something we're all going to have to take a hard look at to make sure that we're able to provide broad vaccine coverage, even in folks that may not be able to afford it.
And someone just wanted to confirm that for those 65 and older population, they only need to receive one dose of the 2024-2025 COVID vaccine.
Most 64 or 65 and older, the answer is yes, but if you've got a person that's immunocompromised, might be undergoing chemotherapy, whatever might be happening with their doctor, talk to their doctor if you yourself are in that age range, because there are some people who would benefit from a second dose, and your doctor can help you decide if that's right.
Let's talk about prevention for a little bit. Would you advise people to wear masks when traveling in airports or airplanes, especially during this flu, these winter months?
You know, I think masks have been found to help in terms of preventing transmission. That's a very I guess I would say personally, it's one of those things you have to decide for yourself if that's an important thing for you to do. If you are planning on masking, also make sure that you're thinking about other areas. You know, if you wear the mask on the plane, but as soon as you get off the plane, you haven't washed your hands, you may defeat some of the benefits that the mask gave you. So be thinking through all of those infection prevention measures that we know work, including blocking it at the point of inhalation with the mask, but then also your hands and how your hands can help you to stay healthy as well.
If you do end up getting COVID, I know there has been Paxlovid. Are there any new treatments or medications available for COVID-19 and, in this season?
Paxlovid still remains the most common one that people will hear about if they get sick. Your doctor may not recommend it for you once you reach out to your doctor. It's not necessarily given every time you get COVID. It's really given in folks where they're worried about severe infection, or they've had a bad reaction to COVID in the past. Perhaps they've had long COVID. So if you are worried about COVID and what might happen, talk to your doctor, especially if you test positive, to see if one of the treatment medications is a good idea for you.
I see one last question. So if anyone has anything else, please drop it in the chat box before we go. Has there been a consensus about the reaction to the new COVID vaccine as far as recovery time and symptoms?
What a great question. I wish we had a good way to track this so that we could get consensus. I'm sure that you're out in the community as well, talking to people, and it's a wide variety that you hear from folks. We have the data from the clinical trials, so we know in the clinical trials how long it took, but community level, we do not have as strong of an answer to that question about what's the general consensus for how long it takes people to recover. But most people, the symptoms fully resolve within 48 hours, including that muscle where it was injected.
Dr. Judd, the questions keep coming, so I hope you're
Yeah,
okay with us
no problem.
continuing to ask. Is myocarditis still more common in males versus females? And do researchers know why this may be?
It's a great question. I have not looked into that lately. It is still more common in males, but I have not looked into whether or not they have mechanistic answers to why it's happening more commonly in males. But that is a great question.
Do you think that there will be a time when COVID medication will be sold over the counter like cold and flu meds?
This is, a little bit outside of my scope as I don't manufacture drugs, but yeah, I do think so. I think it's one of those things. Whenever the company they first make the drug, they want it on patent. They want the doctors to prescribe it at first to make sure that it's effective and that it's being used properly. But if it tends to have very low side effects, so that such that even if a person did not have COVID and took the medication, they would still be okay, then manufacturers do typically want to roll those out to over the counter. So it is in their best interest to do it. And Paxlovid does seem to be fairly safe so far. So it is quite possible in the future that we'll see it over the counter. Now, by in the future, we're probably talking a decade. So just to
Okay.
level set, these things take time to roll off patent and the drug companies have to make their money. But it's so safe, it wouldn't surprise me if it wound up over the counter someday.
Sounds good. One thing that I noticed this season, more on the testing side, is that in addition, when you swab or test for COVID, they also have tests that will test for flu as well.
Mhm.
So you can buy the combination test where you swab once and you get results for both of those. I thought that
That's
was
right. Yeah, that which is so convenient for the consumer.
yes.
That's just so much more convenient.
Absolutely. Well, our questions have slowed down. So, Dr. Judd, thank you so much for this very informative conversation and for answering all of these important questions. This is the time, right, that people are having questions and needing to get vaccinated. So, we so appreciate you taking time out of your busy schedule to talk with us and answer these questions.
Yeah, thank you for having me. It's been great.
Absolutely. And for those of you watching, we hope you will join us on October 23rd at 11 a.m. Central Standard Time for our next webinar, which is on climate change impacts on vector-borne diseases. Thank you again.